researcher, sorry, electrician researcher, specifically a senior lecturer in child health. My absolute pleasure and privilege to introduce a colleague, Professor Jane Daniels from the United Kingdom. Professor Daniels is a clinical trialist and deputy director of the Nottingham Clinical Trials Unit. She has an international reputation for designing and delivering clinical trials in women's health in the UK and the low and middle income countries. So specifically for today, she's speaking to us of the chief investigator of the GPS-3 study, which is a large cluster randomized controlled trial of routine testing for GPS versus a risk factor-based strategy. The results of this study will inform UK, United Kingdom screening policy for GBS and have worldwide implications. She has also evaluated the accuracy of point-of-care GPS tests and acceptability of testing. So without taking up any much further time, Dr. Jane Daniels, you're most welcome. Please go ahead.
Thank you so much, Alavala. Just bear with me whilst I share my screen. Let me try and get this so that you can see everything. All right. Can you see my slides? Okay.
Yeah, they're coming on up. Yeah, we fine. Yeah.
Great. Thank you very much. And thank you so much to the University of Nairobi and Kenyatta National Hospital for inviting me to talk about Group B Streptococcus today. I am actually in Nairobi at the moment. I have been here in Kenya since the weekend because there has been an international conference on Group B strep disease, which I've thoroughly enjoyed, and I will be able to bring you some kind of hot off the press information. So yes, my name is Professor Jane Daniels. I am a clinical trialist and I've been leading on a big randomized controlled trial. Sorry, my slides are not advancing. Okay, just see what's going on. And so I would just like to acknowledge that the trial I will mention is sponsored by the University of Nottingham and is funded by the NIHR, which is the research wing of the National Health Service in the UK. I'm not a clinical doctor. I used to be a molecular.
Apologies for the interruption. Sorry for that. Your
That's okay.
screen currently is showing. I don't know whether you have any Zoom windows currently open on your, maybe the participants of the chat box open. It's appearing as an obstruction on your presentation from our end.
Yes, it's the top bar keeps coming and going.
Yeah, the top bar is okay. Can you check whether you have anything, maybe the chat or the Q&A open?
No, I didn't think so. Let me just come out of this and see what happens. I'm getting a thumbs up. Is that okay to view? I can't
Not
get
yet.
rid of the. No, okay.
Yes.
No, I cannot see anything that is.
Okay, just reattempt your sharing again. For the top bar, I don't know whether you can still see it, but there's a tab called More. It has 3 dots. If you click on it, you can opt to hide the floating meeting controls. Should be one of the options there.
Sorry,
Okay.
I'm not a Zoom expert. I use Teams. Oh, okay.
Right.
Three dots, yes. Hide floating meeting controls. There you go. Right, has that gone? Is that better?
Just proceed. We'll be able to see.
Is that okay for everybody?
Now, would it help if she, since she has changed the settings, if she reshares again?
Oh yeah, yes. You can attempt to share now.
So it's not okay. I thought it was sharing.
No, yeah, just because you've changed the settings, there's an obstruction which is still on, and I think, rather hoping that it.
As I believe now you can proceed. Thank you.
Okay, thank you very much, and thank you again. I'm seeing lots of thumbs up there, so I'm assuming it's working. Let me just hide the chat bar though, so I'm not distracted. Okay. I can't hide that, but never mind. So, as I was saying, I am not a clinical doctor. I'm a clinical trial researcher. I design and deliver clinical trials, and one of which is a GBS3 study that has been funded by the NIHR in the UK. But first of all, I just want to give you some background about GBS. So, next slide, please. And again. So what is group B strep? Well, it's a common, usually harmless gram-positive bacteria that's found in the rectum and vagina of adults and usually has no symptoms whatsoever. But for pregnant women, there is always the possibility of intrapartum transfer from a rupture after rupture of membranes, and certainly the possibility of intrapartum transfer during childbirth. And the consequences of that for the baby is that the potential for neonatal sepsis. Now, early sepsis is defined as occurring before 7 days, and that is most likely due to vertical transfer from the mother. Beyond 7 days and up to 3 months, that is called late onset sepsis, and that is less likely to be direct from the mother. So this schematic shows the consequences of GBS colonisation. So usually it is harmless for the mum, but it can cause maternal sepsis. It can also cause a third trimester stillbirth. But the main problem is, as I've said, neonatal and invasive GBS disease, which can manifest as sepsis, pneumonia, or meningitis. And most babies can recover from that and carry on to develop normally, but there's always a proportion that are suffer neurodevelopmental impairments or cerebral palsy and have lifelong problems. And unfortunately, there is a proportion that die. Next slide, please. So we can detect GBS, and there's been many studies done around the world to look at colonization rates. Here is a meta-analysis of studies by region. In high-income countries, we're seeing a prevalence of GBS colonization of about 21%. That seems to be a little bit higher in Northern Europe, which would include the UK. It's lower in Asia and comparable in Africa and Eastern Africa. And these are rates derived from using the recommended vaginal rectal swab and selective enrichment culture. In the GBS3 study, we've been able to look at the colonisation rates of about 32,000 women split by the ethnicity of the mothers. So we've got a very diverse population in some of our GBS3 sites. The majority of women are white British, but you can see in our study that there was higher than average, the average being 17.3%, higher than average colonization rate in Black women, whether Black Caribbean or African, mixed race, and Bangladeshi women. Just can you move? Sorry, some of these will have and then a study from 2017 at your own Kenyatta Hospital found a colonization rate of 20.5% from vaginal rectal swabs. However, this was using a direct plating method, and I will go on to tell you why that's not optimal and might be underestimating. Next slide, please. Oops, moving on slowly. There have been modelling studies to estimate GBS-associated stillbirth, sepsis and death globally and group them into SDG regions. So unfortunately, sub-Saharan Africa bears the majority of the burden, the highest burden of stillbirths and early onset sepsis, with 20,300 estimated in 2020, stillbirths attributable or associated with GBS, and infant deaths, about 55% of the global burden occurs in sub-Saharan Africa. So it's a huge problem, and unfortunately massive disparities compared with Europe and North America. Next slide, please. If we do look at time trends of rates of early and late onset sepsis in the US, this has been plotted annually by the Centre for Disease Control, and you can see that early onset sepsis in the early 90s was very high and has plummeted during the 90s to a rate of about 0.4 per 100,000 live births. And what happened then? If you click, you'll see that there was the introduction of screening. In comparison, in the UK, we've done triennial reviews of sepsis rates, one in 2020, which already without a screening program showed that the rate of sepsis early onset sepsis in England was comparable with that of the UK after screening had been introduced. However, it has gone up a little bit to 0.6 per 100,000 live births, whereas late onset sepsis maps and tracks that of the US. Next slide, please. Oh, sorry, next bullet. It is noticeable, though, that in England, babies born extremely prematurely and therefore weighing less than 1,500 grams have a rate 14 times higher than babies born in at term or in a normal birth rate. And the case fatality ratio is 6.2%. Now, some information I gathered this week. There is what's called the CHAMPS network in 6 countries in Africa and also Bangladesh. And they've been undertaking sort of mini autopsies by taking some tissue samples, blood samples, and also adjudicating the cause of death from stillborn babies and from babies dying within 90 days. Now, for stillborns, there was 8.2% GBS was detected, and according to the cause of death adjudication, GBS was directly attributable in 2.7% of those. For neonatal deaths, GBS was detected in these deceased infants in about 13.3%, and particularly in the first day of life, there's a higher rate where GBS was directly caused, about 4.7% there. So I'll just pause for a moment and see if there've been any questions so far about the sort of biology and epidemiology of GBS.
Not yet, nothing yet.
Okay, thank you very much. So I'll move on to look at. Oh,
I was saying we can do the Q&A after you finish the whole presentation.
okay.
Yeah, right.
Fair enough, thank you. So I'll move on to screening and prevention now. So in the UK, we do not have a universal screening programme. Instead, the Royal College of Obstetrics and Gynecology recommends a policy of risk factor directed intrapartum antibiotic prophylaxis. So if a woman in labour has any of these risk factors, she should be offered intrapartum antibiotic prophylaxis. The risk factors being confirmed preterm labour, having had a previous baby with a GBS infection, GBS colonisation found incidentally during pregnancy due to a non-routine test, GBS bacteriuria detected in that pregnancy. If there's suspected maternal chorioamnitis or sepsis, or a fever presenting as temperature over 38 degrees, and for the small number of women where colonisation status was known in a previous pregnancy, they should be either offered IEP or offered the opportunity to undergo microbiological testing, and a decision made on whether to take IEP based on that result. Thank you. Can we move on to the next slide? Thanks. So in many other high-income countries, there is a routine testing program, and they tend to use what's called antenatal enriched culture medium testing. So here, vaginal rectal swabs are taken from women, usually at around 36 to 37 weeks, or in three to 5 weeks before an expected due date. These samples are cultured overnight on a liquid broth called limb broth. They're then subcultured onto selective chromographic solid media, and again grown overnight. The chromographic media, if GBS grows, it comes up as like a pink or mauvey coloured spot, and those spots can be those colonies can be taken off and confirmed by mass spectroscopy, MALDI-TOF. So that is a very reliable method, but it does take 2 days to turn around and get a result. Next slide, please. Now, obviously, the taking samples at 35, 37 weeks is not necessarily completely predictive of a woman's colonisation status at birth, and GBS can come and go. It's not known, obviously, how frequently this happens, but in studies where tests have been taken antenatally and then again in an intrapartum test and the results compared, we found that a positive test antenatally has a predictive value of being positive at labour of 93%. So that means 7% have gone from positive to negative, whereas a negative test antenatally, about 3% can go on to become positive by 2.5–3% are positive by the time of birth. So those women are potentially vulnerable because they will not be offered IAP. Obviously, antenatal testing will not cover preterm births, and I say that a recommended method. Oh, sorry, can I just go back one? The recommended method is enriched culture media. So if we look at that compared with as a relative sensitivity to a panel of tests, it will detect 97% of all cases. But if you take a swab and directly plate it onto blood agar with no enrichment step, that is more likely to only detect about 75%. So that's why ECM is recommended, because that's a high false negative rate there. Next slide then. So we're fortunate enough in North America and Europe to be able to access intrapartum molecular rapid testing. So this is a polymerase chain reaction amplification of GBS specific genes, and within that there's fluorescent DNA tags that can then be detected. The market-leading system is from a company called Cepheid, and it's called the Gene Expert System. It's very simple. It can be used by midwives in the labour ward. And so a sample is taken on a swab. That swab is put into that plastic cartridge, loaded onto the machine. That is set running. And in the original version of that test, in about 50 minutes, there will be a result. There is a newer version that is even quicker, and a test result can be obtained in 30 to 40 minutes. So that makes it feasible to be an intrapartum test. So a swab can be taken when a woman comes into hospital in labour, and the results turned around in sufficient time for antibiotics to be offered to those that are positive. Now, I've undertaken a diagnostic test accuracy study looking at intrapartum PCR versus intrapartum ECM. Obviously, the latter was not being used for guiding care. We had a kind of double-headed vaginal rectal swab so that one can go to each test. And we found that it's not as sensitive as ECM, but obviously, it's high enough. We're could be in the 90% range for sensitivity and specificity. And in fact, this week at the conference, I saw some results from a similar study undertaken in Belgium, and their results were a little bit higher. So it is a viable alternative ECM, and obviously it has this advantage of giving a result that is predictive for the status during labour. Next slide, please. So what is intrapartum antibiotic prophylaxis? I can't say that, so I'm going to call it IAP. In the UK, the RCOG's recommendation is that as soon as labour commences, women have a 3-gram bolus of benzyl penicillin, that's penicillin G, intravenously, and then every 4 hours they have a maintenance dose of 1.5 grams. And there is evidence to show that a woman should be exposed for at least 4 hours for that IAP to have benefit. 2 hours is a little bit of evidence that it will be sufficient to protect the baby against early onset sepsis, but we consider 4 hours to be the magic minimum exposure time. For those women who've got beta-lactam allergy, I mean, many women think they have, but they haven't. And so if they've only ever experiencing vomiting, benzopenicillin is appropriate. But there are alternatives recommended for moderate allergies, e.g. cefuroximine, and for significant allergies, vancomycin. But we're instructed not to use clindamycin because of the high rate of antimicrobial resistance amongst GBS. There's just a bullet point more to go on this slide, which is emphasizing that a meta-analysis of antibiotic resistance in GBS from African states shows a very high level of penicillin resistance. Obviously, this is a meta-analysis from many countries, and I wasn't able to kind of check the veracity of the underpinning information, but that does show that antibiotic susceptibility testing is pretty important. Next slide, please. So looking globally, what does the WHO recommend? Well, it recommends either policy of universal screening antenatally, an offer of IAP for screen positive, or a risk factor based policy like we use in the UK. Next slide. What's the evidence behind universal screening? Well, it only comes from observational studies at the moment, and there have been at least 3 systematic reviews. But what they've shown is that testing strategies do halve the neonatal GBS infection rate compared with risk-based strategies. Now, there are caveats to this meta-analysis. There's a range of baseline risk, colonization rates, and methods of detection, and definitions of it, neonatal sepsis. And of course, observational studies like before and after policies have been introduced do carry elements of bias. But for many people, this is sufficient evidence. Many policymakers in other countries, this is sufficient evidence for introducing a screening program. Next slide, please. But not necessarily in the UK. As I said, we're still following a risk-based policy. Our policy-making body is called the National Screening Committee. It looks very, very closely at the evidence for any screening programme, whether that's for cancer or for congenital disorders of metabolism. And there are dozens of screening programs, but they are very cautious before they introduce a screening program into the NHS. And in fact, just recently, they've recommended against a prostate cancer screening program because they needed more evidence. They have reviewed the evidence underpinning these criteria twice, last time being in 2017. And they accept that GBS infections in neonates are an important problem. We understand the epidemiology. We can track the surveillance. We have good surveillance of cases. And they also accept that a simple validated test is available. And thanks to our GBS3 study, the lab capacity is now available. And of course, IAP is an effective treatment. But what is lacking from this criteria is randomized controlled trial evidence. I have conducted one smaller study in women with risk factors, but that was insufficient to look at for them to consider it for the general population. And they are particularly concerned that about the harms of overuse of IAP. They've modelled and calculated that there would be a number needed to test or screen of about 1,800. That means about 1,800 additional women would need to be tested and treated with antibiotics or given antibiotic prophylaxis in order to avert one additional case of neonatal sepsis. That's quite a high number, and that means a lot of women will be given antibiotics unnecessarily. That may have unintended consequences, for example, promotion of antibiotic resistance. And there's emerging evidence that it disrupts the neonatal microbiome. And from that, follow-up studies have looked at babies who have been exposed intrapartum and neonatal period, and they are beginning to see evidence that there may be a slightly increased risk of autoimmune diseases, allergies, and excess weight. So there are some potential impacts on the baby of IAP, and that's why they're being cautious. That said, we have been preparing, and I'll show you the trial. We've been preparing for the possibility of a screening program, and we've done some qualitative research to say that a screening program would be acceptable to parents if given the right information, and to healthcare professionals if given the right resources. Then finally, even in every country, cost becomes an issue, and we'd need to look at the cost effectiveness of screening a program and what resources, what budget impact that would have. So just bring it back home, I had a look at the Kenyan, a lot of information about what you should do. Maybe the seminar later today will give you some more. But what I picked out was that if there are no maternal risk factors for GBS that indicate IAP should be given, women should give birth in a health facility. There's a mention that if women are presenting with pre-labour, pre-term rupture of membranes, they should be screened for GBS and offered IUP if positive. It doesn't say how. IUP should be offered to women with known GBS colonisation, and if during pregnancy they present with a urinary tract infection, they should be offered a GBS test on first catch urine. But it doesn't give explicit details about risk factor-based screening. Apologies if I've missed that and it's in another guideline. Okay, so let's move on to looking at this trial I've been talking about, the GBS3 trial. So it's a rather large trial and it's cluster randomized, which means that instead of randomizing individual women, we are randomizing maternity units. We're going to be looking at the cost and clinical and cost effectiveness of testing for GBS in order to answer that evidence gap that you saw that the National Screening Committee were wanting. It's a very big study. We've finished the recruitment and data collection now, and we're at about we know that we have about 314,000 women in the study. We were aiming for participation from 80 maternity units from England, Scotland and Wales. There were some challenges which meant that we couldn't recruit from Scotland, so we've settled on and finished on 71 maternity units. It was a massive undertaking. This was meant to start in about 2020. Obviously, that didn't happen. We started recruitment in the end of 2021, I think it was now. It took about 2 years. Each maternity unit participated for about 12 months, sometimes longer. If I can give you a little bit more about the trial now on the next slide. So whilst only certain women are tested, the analysis population was all women. That's why we got so many who were attempting a vaginal delivery, or if they were potentially going for an elective cesarean section if they had had pre-labour rupture of membranes. What we did, as I say, we randomly allocated the 71 maternity units to either implement a testing policy or for 36 of them to carry on with the risk factor-based strategy. So that was the main comparison. We also sub-randomized those allocated to testing into 18 units who implemented the antenatal enriched culture testing policy and 17 units that implemented the intrapartum rapid testing using the Cepheid gene expert test for the duration of their participation in the study. And our primary outcome was all-cause early neonatal sepsis. So we weren't just looking at GBS, we were looking at all reasons for neonatal bacterial sepsis, because what we didn't want to do was see a reduction in potentially see a reduction in GBS sepsis, but maybe miss out on noticing an increase from any other bacteria. And next slide unpicks that primary outcome a little bit more. Oh, no, sorry, not quite. So this is how the trial went through. The maternity units were randomized to one of the 3 strategies. They adopted that strategy as standard practice. We had about a 2-month training period where training was cascaded out, and we hoped that at least 80% of women were offered the test by the end of that training. And then, as I say, they undertook testing for between 9 and 12 months, sometimes more, depending on the size of the unit. Obviously, with a trial of that size, we weren't collecting individual case report forms from each mother and baby pair. We were retrieving this information directly from NHS databases, and that was an immense challenge. We were the first group in the UK to go down this route, and it has proved very, very difficult and has delayed results. Because of the size and because this was going to be standard policy for the duration of the trial, we were allowed to have a consent waiver. So we didn't obtain written informed consent from every mother in the study. They could consent or declined to receive the swab if they chose to, but there wasn't a formal consent process. Right, I think the next slide should be about the primary endpoint. Yes. So the primary outcome measure was a bit of a composite. It was the definition that's been used in other studies and is used in surveillance, which is a positive culture of any pathological bacteria from a neonatal blood or CSF sample taken at less than 7 days of birth. We also included neonatal death if sepsis or infection was recorded on the death certificate. But we went one step further, and we know that sometimes there are false negative blood cultures, and there's also babies for whom you cannot take a sample before initiating antibiotics. So we defined clinically suspected sepsis as having had 3 or more clinical signs and symptoms from a menu of symptoms of about 12 signs, symptoms, and lab features, and for which antibiotics were given to the baby for at least 5 days. In the UK, quite often, sample is taken, antibiotics are initiated, and then if the sample comes back negative, they are stopped after about 36 hours. So that was our composite endpoint, but we can obviously unpick the components of that. On the next slide, there are some secondary outcome measures that we're able to collect on everybody. Things like birth weight and APGAR score, admission to neonatal specialist care, from the mother's point of view, if she had sepsis, and quite uniquely, if there was a change of intended location of childbirth. So IEP cannot be delivered to women who are in midwifery-led care units. They have to be under the supervision of a doctor. So in the antenatal testing units, if they tested positive and initially wanted to give birth in a maternity-led unit, they had the option of moving to an obstetric-led unit for that IEP. We also interviewed some mothers and some healthcare professionals to get their perspective on how testing was delivered and how they understood the process and the results that came out. Some more secondary outcomes were on the next page, what we call process outcomes. These unfortunately are not ones that are easily recordable and extractable from the routine data. So these were only collected on a subset of about 9,100 babies directly from the sites. So this is more about the proportion of people who went through the testing steps and how many were offered, how many accepted, declined, how many had the test, the results that came back, and then the offer and acceptance of IEP. And quite importantly, and this will be the outcome used to compare the two testing methods, it's the proportion of test results available in that magic window of at least 4 hours before childbirth. And then finally, we're going to take all that data and perform an economic analysis to see what the extra cost of testing is over and above risk factor-based screening per case of GBS sepsis avoided. So I think the next slide gives you just some little bits of preliminary data, and there's a number of bullet points here. Yeah. So amongst this 9,000 with detailed data, we can see that about 17% had at least one GBS risk factor as identified by the clinical team, and also about 17% were positive for GBS. That doesn't mean that they're the same people. We'll have a look at the intersection of that and probably find out that the predictive value of GBS risk factors is very poor compared with the testing results. I mentioned that we were hoping that about 80% of women were offered and received a test. This turned out to be a little bit lower than we'd hoped for, 72% overall. But that was there was a gap there between the intrapartum rapid test units and the antenatal ECM units. We think that gap is due to the fact that for the intrapartum test, the women were being admitted to hospital. We have a very high, where the test machine was available, the midwives were conscious that they needed to be tested on admittance. We have a very high induction rate. It's getting up to 40% now. So those women are coming in and they can be tested at the point they're being induced. And so there's probably sufficient time for them to contemplate being tested and have the test done. Whereas antenatal services, some of the antenatal care is in hospitals, some of the care is delivered at general practices and in the community. And and the women are the antenatal appointments are very time limited. You know, in the third trimester, there's a lot to go through. So they have unfortunately been missed. We know there's a decline rate of about 8%. So some women don't want to know and don't want to know about their test status because that might change their intended location of birth. And the good news overall is that 80% of those that had got a test result got that test result back at least 4 hours before birth. So that gives that magic window for IAP administration. Now, I had hoped to be presenting the results at this conference that's just happened in Nairobi. It's been harder to analyse the results than I anticipated. We've got a national conference in May, which, if at all possible, I would encourage you to sign up to if you want to receive the results. And at the same time, I'll be submitting this to the Lancet. So look out for publication in the Lancet. It will be open access. Right, so that's the GBS trial. Now, this was meant to be about screening, but I couldn't finish this talk without mentioning future preventative strategies. And at the conference I've just been at, this was the big buzz about the future, and that is the possibility of a maternal vaccine for GBS. I'll just go to the next slide. Obviously, a maternal vaccine, the process would be that you would immunise pregnant women. The clinical trials that have been undertaken that would be at about 22 to 30 weeks gestational age. The women would mount an immune response to the vaccine, the antigens in the vaccine, develop some antibiotics, and those antibodies, that should say, the antibodies would be transferred placentally to the baby and give them protection, definitely against early onset sepsis, but also potentially against the late onset sepsis as well. And there's potential yet to be evaluated as whether it could result in a reduction of stillbirth and preterm birth. Those small fractions that are attributable to GBS colonization, but still important numbers of babies that could be saved. Now, maternal immunisation has only came about during the COVID era. There's now a vaccine available for respiratory syncytial virus, and there's been a lot of debate and discussion about what would it take for a GBS maternal vaccination program. And the words that come up in any discussion are about safety. Nobody wants a vaccine that can cause any problems to the mother or baby. If we can demonstrate safety and do so transparently from the results of the trial, that should generate trust amongst any community and have a high uptake of vaccination. But there will always be issues about cost, about equity and access. So next slide. So there's 4 candidate vaccines being developed. I'm afraid what I've know about them I've picked up from just reading and the conference. The two front runners, there's one being developed by Pfizer, that has gone through the phase 2 clinical trials, and they've published the results for that. It looks like there is going, the hexavalent carbohydrate vaccine, so it's using the carbohydrate capsule of GBS for 6 of the 10 serotypes, has been shown to demonstrate an immune reaction amongst the mum that is transferred to the baby. So the kind of proof of concept has been demonstrated, and they are about to launch a phase 3 clinical trial that will look at whether sufficient antibody is transferred to the baby. And we kind of know now from other studies what level of antibody protection needs to be transferred to reduce the risk of sepsis by 80%. So that's the Pfizer one. The next slide has got one from a company called Minovax, which is a Danish company. They've adopted a slightly different approach. They have fused fragments of proteins that are found on the surface of GBS, on all serotypes of protein of GBS and all strains, and they have also proceeded through phase 2 trials and have got sort of permission from the European Medicines Agency and the FDA in the States for using these baby antibody levels as their primary outcome, and will get that fast tracked through the regulatory process. And there's a link to the clinicaltrials.gov study there. Some of these studies have been conducted in South Africa, so they are looking at women, in as well as the USA and the UK. So looking globally, they're looking at what happens in women who are also infected with HIV. And the next slide, there really is a desire for this vaccine to be available globally. High-income countries may consider it and consider and weigh it up against the cost of screening. For low and middle income countries, obviously it would be a big challenge. But the good news is that the WHO SAGE group have recommended GBS vaccine as a priority vaccine. The Gates Foundation are involved in funding some of this research and hopefully funding some of the production. Gavi, the Global Vaccine Alliance, have also given pre-approval for the vaccine, if licensed, to be on their candidate list. The way in which countries will choose whether to fund GBS vaccine is changing. So it's not guaranteed that Gavi will subsidise vaccines in low and middle income countries, but that will be a country choice. But in preparation for vaccines becoming available, there is this maternal immunisation readiness network across Africa and South Asia, looking at how it can be delivered, and particularly as RSV vaccines available, whether that can be integrated into that programme. The timescale, it's not going to be imminent. Say the vaccines are not licensed yet. They're looking at 2028 maybe for the first FDA or EMA licensing. There will need to be phase 4 trials after that, and then obviously this process of policy change and adoption and implementation will take a number of years. So I can't imagine a vaccine will be available in Kenya within 5 years. I hope it's less than 10 years though. So good news on horizon. So I'd like to now summarise with some take-home points on the final slide, I think. So GBS is a common harmless bacteria found in the vaginal gut of about 20% of women, and women should not feel that they're in any way to blame for transmission of GBS, because it is common and they will not know that they have it. But what we should be aware of that it can be transferred in utero, and particularly during childbirth, to the baby. And what we should be looking out for is early onset neonatal infection before 7 days. So that would be due to vertical transmission, or late onset after 7 days and up to 30 days, which may be horizontal transmission from mum, from healthcare professionals and facilities. And there are known risk factors that can direct to intrapartum antibiotic prophylaxis, IAP. So we should be looking out for those. The ideal IAP is IV penicillin for at least 4 hours, but obviously where there is penicillin resistance, susceptibility testing would be ideal. And we should be all aware of these risk factors and looking out for them both in the mum and then signs and symptoms of sepsis in the baby. Now, it's very easy to say offer screening if possible. If it's not, some healthcare facilities in Kenya, it may be possible. I'm assuming for the majority, it is just not logistically possible. So we look forward to a vaccine becoming available and being rolled out across the world, so that we can protect against this horrible disease once and for all. And then I finally want to say that please, if you're interested in knowing more about GBS, there's an international network that holds these conferences every two years. You've just missed the Nairobi one, unfortunately, but there will be in 2 years' time. We're not entirely sure where it will be, perhaps Asia. But there are newsletters and mailing. You can join a mailing list to get more information. But if you need information, if you have a family or parent who is confused and upset by having a baby with GBS infection, I don't believe there is a national support group in Kenya, but there is a fantastic support group in the UK led by an amazing woman called Jane Plum, who would be more than happy to talk to anybody from across the world and offer support and advice. I've worked closely with her, and we will be hoping that the GBS3 trial does lead to a shift in policy in the UK, because she has been campaigning for this for 20 odd years since she lost her own child to GBS infection. So I'd like to thank you all for listening. Apologies for the Zoom PowerPoint glitch at the end. If you would like to get in touch, that's my email, the trial email, but I can pick emails up from there. And I have so enjoyed talking to you today. I'd like to hear if there's any questions.
Right. Thanks very much, Jane, for that very insightful and exciting talk. I thoroughly enjoyed it, listening to you. Just not seeing any hand up, though in the Q&A, can see I think about 3 questions. So this first one about from Saumu, are there any long-term effects? Presumably, that is long-term effects in respect to the vaccine. And then there's also a question, is there thinking that a vaccine could reduce prevalence of penicillin resistance?
Absolutely.
GBS
Yes.
as well?
Yes, I mean the vaccines they are just emerging, so there's no information on the impact on mother and baby, and there will be looking at whether for subsequent babies there will need to be more vaccines to keep the antibody response high. That's something the companies, I'm sure, will be doing. Yes, another absolute essential benefit from vaccination would be to reduce the amount of IAP being used, and therefore reduce the antimicrobial pressure, keep these antibiotics available for conditions that need them. Does this mean we should always do blood culture for all mothers before? It's not a blood culture, it's a vaginal rectal swab. That's what I mean by maternal screening. And obviously that is only if it's available and there's a lab facilities available to process that swab on agar plates. And as I say, ideally in that two-step enriched culture medium process.
Sorry, are you able to see the questions? Would you like me to read them out?
I can see some of the questions. So, sensitivity and specificity. Okay, so when you're looking at tests, you have a kind of gold standard, and if you assume that a test taken during a sample taken during labour and tested using the ECM method is the gold standard and will reliably detect GBS colonisation. If you're then comparing the PCR test, the rapid test, from using the same samples, what you're looking at is the kind of correlation between the two results. So if ECM is the gold standard, we saw from the results there that I think sensitivity of PCR was about 86%. So that means if the test says it's positive, it is truly positive in 86% of cases. And specificity was a little bit higher, about 89%, I think, by memory, which means if the test is negative, it's truly negative in 89% of the cases. So yeah, PCR is a little less accurate. Rosemary asked for antibiotics if culture wasn't available. I don't know whether you mean if antibiotic sensitivity wasn't available. I'm sorry, I can't advise on antibiotic choice in the if if the culture if maternal culture wasn't available, maternal testing wasn't available, it would still be penicillin. The microbiologist will hopefully, have some idea of sensitivity rates in the local area and be able to advise, but it can be very location specific. So please find out what would be appropriate in your local area. How does GBS accumulate in the vagina? I have no idea. I don't think anybody really. I think it's what's called a commensal. Some women will have it, some won't. It's not necessarily a sexually transmitted bacteria. It doesn't. It's one of those things that if you don't look for it, you don't find. So I don't think there's been any longitudinal studies throughout a lifetime. Sorry, I don't know whether there's any more. You're going to have to shout, Alavala. It's just started raining here, and I can't.
Oh, that's it. Yeah, sorry. Your problem was out of play video. Can you hear me?
Not quite. No.
It's all right. It's all right. I understand. Yeah, it's raining quite raining there. So I think
probably raining where you are too, but
yeah, it is. It is. Yeah, yeah. So we realize we are probably past time, and that's we should have finished at 3
I'm really sorry. I might have to lean into the computer to hear you again.
Okay. Yeah.
No, I'm sorry. I really can't hear anything. Shall we leave it?
Can you hear me from my end?
I can hear Nelson much better than Alavala.
Dr. Alavala, please come again. I can maybe communicate with him too.
Yeah, I'm saying I think it's probably fine to academic authors, we also sent it the content, one really, very much of them who's great piece of work with us and let's things to think ahead to the context and then to the context. And then look at the
Um, I, Dr. Alivala, hello, I think I also couldn't get I also couldn't get much of what you were saying from your end. I think your sound is a bit muffled.
any better one?
Maybe you could just type on the chat box as a direct message. I'm not so sure whether you had finished going through the questions in the Q&A.
I think he was. I think he was just saying thank you. Well, I mean, thank you very much to all of you too.
All right. Thank you as well for taking the time to take us through your what your clinical trials have been about. We do appreciate, and we will welcome you, or we want to welcome you once more if you do have the time for another presentation to come and educate us. Thank you.
Thank you. It's been my pleasure talking to you today. Thank you very much, everyone.
All right. Dr. Alvala's has just come in. He was indeed saying thank you, Jane, for the presentation, and also thanking the participants for joining us all through. Thank you for your support. And from me as well, I just want to make a few last announcements as uh, advertised before. We will be having a session much later today, and this session is from Ministry of Health, from the uh, Division of Reproductive, Maternal, Newborn, Child, and Adolescent Health. They will be taking us through the intro labor care guidelines. This is a series, and this will be the first to introducing us to the labor care guidelines. It will be a monthly event, so look out for your on your emails for the notifications of this particular series. Tomorrow as well, we'll be having one session, a neurology series, which will be introducing us to seizures and epilepsy. This will be at 7 p.m. So do also join us for that talk. Thank you once again. Thank you to our presenters. Thank you, Dr. Aluvala, for the moderation. Do have a wonderful afternoon.
Thank you very much. Good afternoon, everyone. Bye.